So continuing the tradition, for those of you who would like to make comments or ask questions, please go to the mics and identify yourself. The question I will ask to start was a lot of what I've heard over the last couple of days has been from the patient focus, and particularly when we look at the issue of transitions, whether it be pediatric to adult or inclusion of a service such as palliative care. Is there work going on the provider perspective? And I ask that from a recent conversation with an individual who runs a survivorship clinic, to whom many of the medical oncologists do not want to refer their patients because they still want to see their patients 10 years out because they're doing well, and that's a positive visit. So this is an adult population, it's not an AYA population. But that struck me that there's not only from how we may look at the patient or family perspective, but what about the provider perspective of the letting go and facilitating transition? And is there work going on related to that in AYA or anything you all would share?
It is a problem. If it's not documented, certainly there's a strong clinical impression that that's a problem. I encounter it, I mean, even in my own institution, and most of my colleagues in pediatric cancer survivorship, run into the same thing. My own observations are that it's well-intended and it's easy to understand where the reluctance to refer to a cancer survivorship program comes from, because these patients and their physicians, and again, we heard it really eloquently stated, I think, by the survivor panel last night, there's a really strong sense of connection and a bond that's easy to understand where that comes from. Personally, I don't think it serves the best interests of the survivor when it interferes with getting appropriate survivorship care. There's an important study, I think published by Tara Henderson, that looked at the knowledge base and skill set of pediatric oncologists in implementing survivorship care using a case vignette of a Hodgkin lymphoma survivor, I believe. And it was really striking how low the level of knowledge was about appropriate risk-based screening for this, fictional case of a female survivor of Hodgkin lymphoma who had received radiation therapy and anthracyclines. So even within our own field of pediatric cancer survivorship, I think that, that actually interferes with care. The only other observation, and I'll let my colleagues respond, is that my own observations within my institution are that there's a little bit of a generational shift occurring with this. I find that the most recalcitrant physicians are those who are older and have been in practice for a while and are not familiar with, the concepts of cancer survivorship. Here, I think we have an opportunity with training and exposure. My observation in my 5 years at CHLA has been that since we sort of formalized our cancer survivorship program with the model that I showed you, and we've involved the fellows in the cancer survivorship program, when they become junior attendings, they have no hesitancy about referring to the survivorship program. So I do think there will be change probably that will continue over time. I think it's sort of a learning curve. So I guess I'll stop there.
Yeah.
I think David's observations echo my experience as well. And even at St. Jude, where we have a huge survivorship program, we still have some attendings that are noted to keep their survivors, and they actually transfer them over just before they're due to graduate from the after completion of therapy, so they can get their survivorship care plan. And we do, and then we realize they haven't addressed issues for many years. So what we're doing, and it's not in a research focused method, it's in a quality improvement scheme, is we're offering shared care, just like we do with community care. We're offering shared care with the treating sections, to where if they feel like that survivor still needs follow-up for whatever reason within the treating section, we can be seen in consultation and begin those transition issues. And another avenue that we're currently exploring, and it came about because the families heard, what about your clinic and why aren't we going there, with certain pockets? And so our Family Advisory Council is working with us and to try and understand why it's not the clinic and long-term survivorship programs are not consistently promoted, because they recognize the need for their attending, who have, they have this very strong bond, to promote the use of that clinic and those resources. So we're going in different directions to try to address getting them into follow-up.
If I can just add one thing, we've done the same thing. The model that we use in our institution is one that doesn't require, complete referral and loss of the patient, if you will, to the cancer survivor program. We have two parallel tracks. So once the patient's referred into our program, and we actually try to capture these patients or engage them, much earlier than traditionally has been the case. We try to actually get them referred into our survivor program basically once their acute toxicity has cleared and within 2 years of ending therapy, rather than traditionally, waiting the 5 years from diagnosis or 2 years off therapy. And what we've done is we've simply developed sort of a parallel track. So if the primary oncologist, well, there's two purposes for this. One is that many of these patients are still in disease-directed follow-up because they're getting referred earlier to the survivorship program, so they actually need their scanning for disease monitoring, and we don't do that in the survivorship program. So that's one thing. But the other thing is that if there does happen to be an oncologist, who really feels it essential for whatever reason, for either, himself or the survivor, to keep seeing the patient once a year, years out, they're perfectly free to do that. And, we encourage it if that's what the patients want and the physicians want. So it doesn't really need to be a barrier. They don't really give up the patient, sending them to the survivorship program.
Elise?
So at MGH, we started a survivorship clinic a couple of years ago, and I think in terms of the provider education, I think there's definitely a difficulty in the referrals of patients with high psychiatric comorbidity, so a lot of access to patients. So we need to do some education there. The second thing is we're starting a group program for patients who see the social workers during their treatment when they come off treatment, to do a transition to survivorship program, which I think will meet the needs of the social workers from a mental health perspective, because at some point they have to stop treatment with patients. And the third thing I just want to say, which is I haven't heard as much here, is that the real challenge of the tension between who treats the patients within oncology versus primary care, and what is the best shared model. Because I know within our cancer center, there's work being done to try to educate primary care physicians to work with these patients, but I think there's also a lot of system barriers to really having a shared model like that and really figuring out where do cancer survivors fit best.
Dr. Levine?
I just wanted to follow up on a very specific point that Dr. Fryer and Hudson brought up. Thank you very much for separating out the issues of fertility and sexuality. And it just reminds me that I always have to remember when we're talking about risks for infertility, that they're risks. It doesn't necessarily mean you're infertile, and it has nothing to do with sexually transmitted illnesses. And that probably at the same time that we have the conversations about fertility, we need to be talking about contraception and protection against those sexually transmitted illnesses. Sometimes those messages, I think, get confused for people, and they think, all right, well, that's not something I have to worry about. So thank you for separating those.
Hi, Ruth Reckes, Livestrong Foundation. I just wanted to add to the prior conversation. There's an excellent resource, Focus Under 40. That was a partnership between Ascot University and the Livestrong Foundation to address providing support in the 2 AYAs, and there's a survivorship module that is a component of that. And one thing we had heard is that there's not always care available for someone to go to, which may be why they go back to their oncologist, which is some of what Benjamin was talking about yesterday too. So the intent behind that in some ways was to help others know how to do this and to work with primary care physicians around how to transition that care. And in the Center of Excellence Network, we've done a lot of work to create materials and things to help with that transition piece too. And I'll look to Dr. Gantz to correct me if I'm wrong, but I think the U.S. Preventative Task Force will cover, the recommendation is to provide screening for those who had a cancer diagnosis that are high risk, and ACA would cover it. Yeah.
Just to clarify, U.S. Preventive Services Task Force, Dr. Blyer mentioned this yesterday, those recommendations are for usual risk individuals, high-risk individuals. If you are a BRCA1 or 2 carrier, if you've had a biopsy that shows a premalignant lesion, any of those things are not under the purview of the U.S. Preventive Services Task Force. And we routinely, in our survivorship program, if we have somebody who's had chest radiation, We recommend starting screening 7 to 10 years later. We have it in our treatment summary and care plan. The primary care doctor then faxes it into the insurance company and they get approval. So I don't think that that's going to be a barrier, and so we shouldn't try to perpetuate information that isn't quite on target. So U.S. Preventive Services Task Force are usually for usual risk individuals.
Okay, so my understanding was not all, but what about patients of all insurances get that covered? Because my understanding was only certain insurances were covering those.
No, we don't have any. I mean, I've been taking care of BRCA 1, 2 carriers who are unaffected. There are guidelines by healthcare organizations that insurance plans follow for high-risk individuals. I mean, for instance, the individuals who are at risk for breast cancer and take tamoxifen, that's a high-risk group. We have Gale models. Kurlikowski had a really nice paper in the Annals of Internal Medicine identifying high-risk subgroups for whom the usual screening criteria do not apply. So I think, again, we shouldn't generalize that these things are going to be denied. And just as Dr. Blyer mentioned, somebody with a mother and a grandmother or a sister with early onset breast cancer, we start screening them much earlier. So, and that would be the same for any hereditary predisposition colonoscopies, which might not be covered until age 50, or even fecal occult blood testing. If you are an individual who has FAP, or if you have HNPCC as a genetic predisposition, you get started screening, in your teens and 20s for FAP. So again, I think the issue is general population screening, which is what mostly the U.S. Preventive Services Task Force guidelines address, versus high-risk individuals. And again, we've been talking about the AYAs as a high-risk vulnerable population. The question is, other screenings like the echocardiograms and some of the other things for the COG guideline-related issues, insurance companies may balk on those, but I think where we have a screening test that we know in the general population saves lives when used at an appropriate age, then it's translated into that high-risk group. So I just wanted to clarify.
Thank you. The quote I shared and the experience as a patient who was not able to get that covered, but thank you. Appreciate it.
Thank you. I did actually have a question also. One of the things that we were really excited about as a part of the Young Adult Alliance and now what's transitioning to critical mass is all these community-based organizations that are engaged in providing resources and services and physical activity programs, exercise programs, nutrition information, and are really good at getting adolescents and young adults to participate. First Ascents has been mentioned a few times, and we've talked about how it is difficult to get adolescents and young adults to participate in research and to get them all the resources, and then it may not be possible to provide unique services when there are so many competing needs out there. And I just wondered if you all had any thoughts on how we could best engage community-based organizations. We saw from Rebecca's presentations that most of those programs are referring out. So how do we thoughtfully engage those groups in providing care and in helping us with the research potentially? They may not have the resources, but there are interesting partnerships like Jackie talked about where we could help them to help us collect the data we need for the questions we have.
Well, I think the Livestrong association with the YMCA programs, I think it's going to vary per community and what the resources are there, but it just takes a few connections to find some interested community-based organization or individual who's been affected by cancer who can buy into your cause. So I think it does take a lot of work, but I think it's critical in disseminating some of these health promotion programs to our survivors at point of care.
It's a great question, and I think it depends on what the endpoint is. If in our own survivorship program, we have found a useful alliance with our teen support group called Teen Impact. So this is, if we draw an analogy, this is within CHLA, and perhaps the same kind of relationship could be pursued with community-based partners. In fact, we're pursuing a couple, but we've found that it's a mutually supportive relationship. The Teen Impact program draws in, survivors predominantly, and a good number of them are not actually being seen in our survivorship program. So Teen Impact will kind of plug, the importance of, for all the reasons that have been discussed here, of getting back into follow-up. And we have every year quite a few patients who come for their first-time survivor evaluations because it was pushed within the Teen Impact program. And then vice versa, we actually mention Teen Impact. It's in our standard material that we deliver to our survivors of an appropriate age. We tell them about Teen Impact, and many of them actually get involved in the retreats that they wouldn't have known about if they weren't coming to the survivorship program. So I think those kinds of mutual, support relationships can be very helpful. In terms of research, though, I'm not sure it's as valuable. We've talked about doing research in our own population using Teen Impact because they do have this pool of individuals who are coming back. But the problem is that there's a huge, selection bias because these are individuals who are choosing to go. And of course, the ones that who, for whatever reason, don't want to be part of Teen Impact are not going to be represented in research. So it really calls into question the validity and generalizability of the results.
Thanks.
Yeah, last question.
I had a question for Dr. Baker. When you're establishing your relationships with hospice agencies in the community, when you're not able to offer curative intent with therapy, could you speak to kind of the education that needs to be ongoing when they're caring for an AYA who, I think there's some important provisions in the Affordable Care Act about concurrent care, so you don't have to be cut off from your oncology team and still can get hospice care in the home. And I think that's made a big difference, like for patients that we care for, because they slowly want to shed, depending on what their goals are for the time that they have left. They may want to shed certain appointments. Maybe they don't want to go back to their ophthalmologist to check on their cataract, but but they many times still want to stay engaged with the healthcare teams within the cancer center where they're getting their care. And I know we've gone through a lot of discussions with the hospice agencies because we have one hospice agency, for example, that serves our greater Los Angeles area, and they have two branches, one for adults and one for kids. And when I have a 26-year-old who has an end-of-life issue who wants to die at home, they actually, through discussions of both teams, decided we would go through the kids section because they had more appropriate services about just wanting to get out, continue to live, and not be with possibly the 80-year-old who has a very different end-of-life wish list than a 26-year-old. And it just was wondering about your experience in that area of developing those relationships for the right AYA education.
Yeah, I think this is actually very important. I think first it's educating hospices about the Affordable Care Act. Not all of them even recognize they have so few patients that would qualify under that they could receive cancer-directed treatment along with hospice-based home services. But the other thing I would say is there's a lot of barriers, just like palliative care. The word hospice is much more hostile than that. And so we changed our name of our program in our community to the Koala Kids program, which stands for Quality of Life for All Kids, but it is for adolescents and young adults all the way up to age 26, actually, as you mentioned. And what we do is we advertise this as something that we can get earlier in the disease trajectory. So it's not used in a typical hospice model, which would be the last month, maybe the last 2 months of life. But these are patients with very high risk disease, and if they qualify for kind of home health provision, we will enroll them in this program with the anticipation that they'll eventually qualify for hospice. But they use the program in the same way. They it's only an administrative switch, so that the home health nurse, that sees them for their home health, their 10 home health visits or whatever they have, eventually becomes their hospice nurse. And so it really facilitates relationships across this trajectory like we talked about. It's so important to be able to have those relationships and have that established well. I think the other piece of this is making sure that, as I mentioned, I think this population, especially, these rehab issues and wanting to get up and be active and do these kinds of activities, it's very important to have that as a piece of the program. And so we right away recognized that, and we brought physical therapy in and other rehab services that we can do in the home. And this takes a ton of education because on one extreme we have, a pediatric oncology program that is very kind of, protocol driven and not a lot of flexibility. But then on the other side, you have an incredibly loosey-goosey hospice that can be kind of, sway in the wind with where things go. And realistically, where many of our patients want to be is in the middle. So they want to be able to come back to the clinic when they want to, but they also want to have clinic-based services provided in the home when they don't want to go to the clinic. And so we have a lot of this negotiation, and it's difficult not only on the hospice side, but also on the clinic side to help people understand what we can and can't do in the home setting, and trying to push for both the oncologists and the hospice to do things a little bit differently and to think about it a little bit differently. And it's something that just over the last year and a half, this program's very new, but it's really helped, and probably about half of our patients have been adolescents that have come into this program, and it's been very helpful for them to have this option. So we have one patient we're taking care of right now. On a day that she just doesn't feel like coming in, we'll go to her and we'll draw labs, and we'll bill that kind of through the hospice modality. But then when she actually comes in and receives her cancer-directed treatment, she's getting that through the actual provision of care aspect of the Affordable Care Act. So it's been tremendously helpful, this program. It's very different in hospices as you refer out, but at least we can provide the education. There's actually a toolkit for the Affordable Care Act that's and its application through the Center to Advance Palliative Care. So that's capc.org. And if you go there, there's a whole toolkit that they have for hospices to be able to apply Affordable Care Act standards to their hospice. And it opens up the new provisions that are required.
Patty.
So I had a comment in response to Ruth's issues about the community, but I just also wanted to thank Dr. Baker, because we're struggling with the integration of palliative care and adult oncology. And I think, the things that you're doing really are generalizable. I mean, obviously you're dealing with a very special population and needs, but I think we need to let everybody know in hospice about what the Affordable Care Act can allow now for people, because there will be people under 65 who will be either underinsured or uninsured who will benefit. So I've learned a lot from what you've said, so thank you so much. But I want to speak to Ruth's issue about how can we engage the community, because obviously for this patient population, this is very important. And I would like to suggest to these research leaders who we have at the table, and I'd like their response and reflection on this, is that I think we're never going to probably have enough centers, even in academic, as you've shown already, that was reviewed. Many comprehensive cancer centers are not going to have this, and we can't expect community centers to have AYA programs because the numbers are just too few to invest those resources. But what about your programs and academic leadership in this being the engines of change to develop programs? Because a lot of what we're really concerned about in the clinical research field is that we show that something works and then it never gets implemented. If we could, at our institutions that have a focus on AYA, have evidence-based or evidence-informed interventions that work because you've done a liaison or you've already developed something that's very effective in your institution, then to do that translation to implementation into these community organizations. Because again, my experience now with our CDC Younger Women project, we are developing a tailored psychosocial intervention with the expertise of our wonderful psychosocial program at our center that we're going to be able to deliver at 2 community hospitals, first one that has a Latina population, the other that's in the community, and then it's going to go out to the cancer support community and all of the other community organizations that exist across the nation, but told us that we would love to serve this population of younger women, but we don't have the tools, we don't have the experience. If you develop something and can help us, we'll put on this program. And so our goal is then to show that it works, then developing the manual and the training ability to then allow others to take up, what our best practice is, so that maybe on a continuous basis they can't do something, but they can have programs, they can they can have strategies to get people, these young folks with their peers and so forth, give them the toolbox that will allow them to do what you do so effectively in your centers where you have so many patients. So to me, that seems to me the most realistic and efficient way, rather than to expect every community hospital to be able to have this. So I'd like your reaction to that kind of proposal.
Well, I can make a comment. We struggle all the time with being blessed and being in an institution that has a lot of resources to devote to patient care that extends to long-term survivorship care. And we are very cognizant of the fact that what we develop has to be disseminable, and it has to take the perspective of how would one implement this within a less resource community setting. So we have a lot of ongoing trials where we do in a randomized control fashion, we assess things and then determine what are the components and how can that be translated and what's the next step to sort of lower, well, I shouldn't say lower, but to minimize resources to be able to achieve the same behavior. So we're cognizant of it. I'm not saying we're successful in everything we do, because I do think it's not just it's time and having a champion to within the community where it's going to be. And so learning what other, it doesn't have to be the MD, it doesn't have to be a nurse practitioner or a psychologist. There may be an individual with a different type of training that could be done within an office setting. So we're trying to work within those models to serve the needs of a broader survivorship population.
Thank you. Oh, go ahead.
I just would, I guess, echo what Melissa's saying. I think the point you made very nicely the other day about AYA programs, or maybe it was this morning, I remember the days are blurring, that not every place can develop one, and all of the programs are sort of one-off programs. That's true for survivorship programs too. They're all different. When you go around and talk to, our colleagues, they're all structured a little differently because of the local, needs and peculiarities, but they all sort of accomplish the same thing. So I think your point, is really well taken in the survivorship world as well. I sort of personally believe that because of the, the only way that we're going to really, I think, penetrate, the landscape with survivorship care is to utilize the general practitioners and or family physicians, primary care providers to a greater extent, whether those are physicians or nurse practitioners or accountable care organizations now under the ACA. I think we have to figure out somehow, how to differentiate among the patients who really need the high intensity follow-up and those who are probably going to be okay even if they don't show up for their appointments.
I think with this research, there are two areas that we have to challenge ourselves as researchers to do. And one, Karen had mentioned mechanisms, figure out why our interventions work, drill down, and also cost. If we're really going to disseminate these things, how much would it cost and how could we think of lower tier costs? And it's hard, I think, in the work that we do in terms of the grants that we get to really be able to thoroughly look at those two areas, particularly cost, because it's cost to document cost. But I think it's very, very important and something we're starting to do more of and will facilitate dissemination.
So please join me in thanking the panel for their excellent presentations. And I would invite Tom Keene to the podium. Tom is President and CEO of Sea Change, and he is going to summarize the last day and a half of our workshop with the themes that he's heard. Thank you, Tom.